Thanks, Lou. Evening, everyone. Hope you've had a good day at the office today. I know for myself it's pretty warm, and an FFP3 mask for a couple of hours is quite an interesting experience, but at least we're back at work and we're trying to sort things out. I want to talk to you about this particular subject this evening because really irrigation at the moment is probably one of the main focuses of endodontic therapy. I mean, certainly we have a whole raft of new endodontic instruments coming onto the market, which makes life really quite interesting when we start looking at a different metallurgy. But when we're looking at, let me just set this up, our endodontic processes, we basically split our endodontic processes down into four separate processes. So the access cavity obviously allows us to identify the root canal anatomy, identify the restorability of the tooth, assess for fractures. The shaping allows us to create an apical size and a taper or increase the canal volume to allow us to then clean the canal spaces. And this in then turn allows us to seal those canal spaces. But the reality of the four pillars of endodontic treatment is all four are intimately related. So if our access is wrong, that can make shaping more challenging. And if our shaping is wrong, then it can make it harder for us to clean the canal system. If our access is correct and our shaping is appropriate, we can clean the spaces well, which means we can seal the spaces. And you have to bear in mind that our obturation completes with our coronal rehab. So just to come on a little bit further onto the coronal rehab side of things, this is Elias's paper published in 2015 in the British Dental Journal. It was a review paper, and what it looked at was the good restoration and good endodontics by paper, and you can see the numbers here. And what's really, really important is there's a general trend for the coronal restoration having a huge impact on the outcomes of endodontic treatment. So it's extremely important that we understand that we might well shape and clean appropriately, but if we don't restore well, then we are leaving our endodontic treatments open to failure. So when we look at, for example, this paper by Pratt published in the Journal of Endodontics 2016, they found that teeth that were endodontically treated that had just a core restoration afterwards were twice as likely to be extracted compared to endodontically treated teeth that had a crown. But interestingly, in this particular paper, what they found was that endodontically treated teeth that had crowns or cuspal coverage within 4 months of the root canal filling being completed were 3 times less likely to be extracted. So the timing of the coronal restoration also appears to be important. So when we're looking at our endodontic diseases, basically we're dealing with a microbial infection of a necrotic space. So in order for that to happen, the pulp must have become non-vital, microbes must be present, and we then have the host response, which is our apical periodontitis. So in theory, if we can reduce the microbial level to a point where the host response switches off, then we heal our endodontic disease. Now, the problem that we have is that our endodontic shaping processes are predominantly done with round instruments. So the cross section of our instruments create a round hole. And we know that our canal shapes are very rarely round. And so if we look here, we can see that residual tissue left behind is going to provide a source of nutrients for microorganisms that can potentially perpetuate our endodontic disease. And you can imagine here, if this is also infected with bacteria, then that bacteria has an opportunity to interact with the host either through the apical foramen or through lateral canal anatomy, and then cause persistent endodontic disease. So looking at our traditional shaping processes, we can see that when we move from a 10 to a 25 to a 40 O2 taper file, we can contact more of the canal wall. If we can contact more of the canal wall, we can get better debridement of the canal wall. If we can get better debridement of the canal wall, we can hopefully reduce the microbial load and improve our endodontic outcomes. The problem that we have is our endodontic instruments, if we look here, even up to a size 40, do not contact all of the canal wall. So if our instruments aren't debriding the entirety of the surface of the root canal, that means we have a problem. That means we are leaving stuff behind. Now, the other problem that we have with our shaping processes are we subject the canal to artificial shapes, so we call these transportations or ledges. We can run the risk of fracturing an instrument, but we also create debris and we create sneer layer. So the debris that we create, particularly with rotary files or reciprocating larger taper night-eye instruments, the debris can only go one of three ways, up, down, or sideways. And if we have an oval canal or if we have an unusual anatomy and we get debris packing laterally, that lateral packing of debris is going to block the actual dentine itself. And if we have an infected case and we don't remove that debris, then we're going to struggle to get the maximum antimicrobial effect of our treatment. Combined with looking at the way the microorganisms exist within the root canal system creates us a genuine problem, because we haven't just got microorganisms in the lumen of the canal, and we can get biofilms in the lumen of the canal. We have this polymicrobial infection that adheres firmly to the root canal wall. Now, the other problem with this is we also then get a superficial layer of infected dentine where the bacteria penetrate the dentinal tubules. So we have to fight microorganisms in three separate distinct areas of the root canal system: the planktonic microorganisms, the biofilm adhered to the dentine wall, and the superficial layer of infected dentine. And there's no question, if we can scrape this off with an instrument, we are going to get effective debridement. But if we accept the fact that our instruments cannot contact all of the canal wall, then we have to have an adjunctive antimicrobial technique in order to deal with the untouched canal walls, deal with the superficial layer of infected dentine, and to try and disrupt the biofilm on the root canal wall. So here is a clinical case, a typical example of a case where it's actually an upper canine, and we've accessed, and during the shaping and cleaning process, this is the residual pulp stump that came out. Now, this residual pulp stump, the tooth was symptomatic with apical periodontitis, obviously testing negative to sensibility testing. But this residual pulp tissue, you can see the black area here, which is likely to be biofilm, but this is going to create an environment where microorganisms are going to persist within the root canal system. So our irrigants don't just have to be antimicrobial, they have to deal with these bits of tissue that are inevitably left behind if we can't remove them all mechanically. So when we look at this failed case here, this was the mesiobuccal root of an upper first molar. You can see it's been obturated in the past, single canal. And if we look closely, even though zinc oxide is predominantly, even though gutta perca, sorry, is predominantly zinc oxide eugenol, we can see here we have a sea of biofilm surrounding the space where the sealer has been lost, and bacteria have been able to invade the gaps between the gutta perca core filling material and the dentinal walls. So this is what causes persistent endodontic disease and causes our treatments to fail. So when we come to look at the paucity of our shaping processes, Peter's paper 2001, Subtraction Micro CT, suggested that regardless of the technique of shaping that you use, 38% of the root canal remains uninstrumented. So in other words, 62% of the root canal only was contacted, regardless of the taper of the instrument, the apical size and shaping. So that means we then have to have a combined technique to have an antimicrobial effect. And again, if we look at Frank Bacquet's micro CT of an upper first molar, from the buccopalatal, which is a classic image that we would take radiographically, it seems that we have a relatively uncomplicated root canal system. However, if we turn that image through 90 degrees, we can see that actually the root canal system is significantly more complex than it appears. So if this is the case, and we shape these canals with round files, if we don't locate the anatomy, then we're leaving ourselves open to problems in the first place. But if we have shaping debris packing into these little nuances of the root canal system here, if you remember I said about the superficial layer of infected dentine, if that's packed with infected dentine, then the potential for persistent endodontic disease is going to carry on. So when we're looking at our endodontic irrigants, our current irrigating systems have required us to use more than one endodontic irrigant to achieve our goals of antimicrobial effect, debris removal, prevention or removal of smear layer. And this means that we have to have multiple processes during our endodontic treatments. And this is time consuming, can lead to problems regarding mixing of irrigants together. We certainly know that sodium hypochlorite and chlorhexidine don't mix well together because they form a precipitate, which is potentially carcinogenic, parachloroaniline. So when we're looking at our irrigating systems, if we try and create a simplification, that can only help us. So the reason for putting this images up here is simply because we are looking at using CE marked products wherever we can. And we've traditionally used two particular irrigations, sodium hypochlorite, anywhere from 0.5% up to 6% or 5.5%, and a separate EDTA solution to remove the smear layer. Now, the problem is, even though these are two primary irrigants, they interact. And we know that the EDTA will remove the smear layer, but we also know that EDTA stops sodium hypochlorite from being antimicrobial. Now, the sodium hypochlorite doesn't stop the EDTA from removing the smear layer, but we lose the benefit of the antimicrobial activity. And what if we could have a system whereby we can actually prevent the smear layer buildup? Now, is this video going to play? It was earlier, but it might not here. Okay, no. So the problem that we have is interaction of EDTA and sodium hypochlorite. So relatively recently, there's been work done on looking at creating an irrigating solution that gives us the benefits of sodium hypochlorite and EDTA together, but without creating this interaction whereby we lose the antimicrobial effect. And so what has been brought to the market is something called dual rinse, made by Medsem. Now, dual rinse is a combination of sodium hypochlorite and etidronic acid, which is a bisphosphonate. And what it's been found is bisphosphonate can act as a chelating agent without stopping the sodium hypochlorite from being antimicrobial. So by mixing these two products together, you can actually use one irrigating solution during your treatments rather than two. So we get prevention of smear layer buildup, and we still get the antimicrobial effect. Also, we get the lubrication of our instruments by having them soaked in this liquid. So the literature from the company is talking about a specific principle and a specific methodology. So the idea is the dual rinse or the etidronic acid comes in capsule form. So the capsule is then emptied into sodium hypochlorite, mixed together, and then used as a single irrigant. Okay, so this simplifies potentially our endodontic processes. So this particular system works by mixing one capsule here with 10 mils of sodium hypochlorite. And then we can draw that up. So you mix it for 60 seconds, apply it into your access cavity, replenish regularly, and go through your shaping process. We still need adjunctive cleaning systems because we are still going to create debris and we are still not going to contact all of the canal wall. So some of the literature that's been published here on the use of hypochlorite and netatronic acid showed the ability, this is part of Matt Zender's group here, showed that it did have the ability to prevent smear layer buildup, and in this particular study here, coming out of the Brazilian group, showed that it would still maintain the ability of sodium hypochlorite to kill E. faecalis in the biofilm. So potentially, moving forward, this is an option for us to be able to use a single irrigating solution rather than using multiple irrigating solutions. Now, the other thing that plays a significant role in irrigant delivery within the root canal is needle design. So if we look at needle design, you can see we've looked at, or this is particularly Boutsiukis' work, several different needle designs in endodontics. We know that the closed-ended needles here, you can see these three needles here have a closed end, are the safest way to irrigate a root canal. The problem is when we look at computational fluid dynamics, you can see it's also extremely ineffective at delivering irrigant into the apical portion of the canal. We just don't get irrigant flowing. So when we look at the open-ended needle designs here, we can see that we get better irrigant flow. Now, the problem when we have a flat-ended or blunt-ended needle like this is if that gets wedged into the canal space, then the irrigant can only go one way, and that's through the apical foramen and under pressure. This is where we get sodium hypochlorite accidents occurring. So the compromise that we use is a side-vented needle. Now, a single side-vented needle means that we don't get any irrigant on this side. And if this still gets stuck in the canal, then we still have the potential to have irrigant extrusion. The other thing that's really important is understanding needle size in relation to canal preparation size. So whether you are keeping a small taper and a small apical size and a larger taper, which is the Schilder concept, and a lot of instruments do behave that way. So for example, if you looked at the Pro Taper Universal or Pro Taper Gold or the Reciproc R25 or the instruments that are designed to have a small apical size and a greater taper, then you create volume and space relative to your needle. If you have a size 40, a size 27 gauge needle, that irrigating needle is approximately an ISO size 40. If you have a 30 gauge needle, the ISO size of that needle is approximately a size 30. So provided you've created space and you control the depth of insertion, control the flow rate, and make sure the needle isn't wedged into the canal, you should be able to deliver irrigant safely within the root canal environment. You cannot create a flow rate in a root canal high enough to power wash the biofilm off the canal wall. So delivery of irrigant within the root canal space by syringe delivery is purely to allow delivery of the irrigant, replenishment of the irrigant into a certain place within the root canal system. The other problem that we can get with traditional syringe irrigation is sometimes get an air bubble in the apical portion here. So what we need to try and do is deliver the irrigant safely, but then stir the irrigant up within those spaces to try and disrupt the biofilm, get rid of shaping debris, get rid of the smear layer, create tubular penetration of the irrigant to reduce the microbial load as much as possible. So recent developments in irrigating needle design has come out of a particular company called Produit Dentaire. And they've produced a needle called Irriflex, which is completely different from any other irrigant delivery needle that we've had in the past. It's a standard Luer-lock system that has a 60-degree angle. It had depth marks here of 18, 19, 20, and 22 millimeters. It has a 30 ISO or 30 gauge or ISO 30 tip with an 04 taper. Now, the clever thing about this particular instrument design is not only is the tip made from a polymer material, which gives it great flexibility, it also has the ability to deliver irrigant on both sides of the canal. So it has a safe tip because it's closed-ended. So you can see the tip of the needle here is closed, and it has two lateral vents here in the apical 1 millimeter. So providing our canal preparation is of sufficient size to prevent needle binding, we have a safe-ended tip and potentially the ability to deliver irrigant on both sides of the canal wall. Now, is it perfect? It's better than what we've had in the past. And being flexible and being a polymer, it means you can introduce these instruments into the canal safely without fear of it breaking, and it will follow the canal curvatures. So if you look at this VT here, the canal has been prepared to a 2508 taper. So there is plenty of space here. Okay, traditional steel irrigating needles, side vented, monojet design, blunt-ended, side-vented needle. Okay, so provided the needle is not bound in the canal and can move freely, and we don't try and power hose the inside of the canal, we deliver our irrigant at a steady, gentle flow rate, it has the potential to be a safer way of delivering our irrigant. So once we've shaped the canal and delivered our irrigant into the space, we then have to consider how are we going to actually move that irrigant around to effectively clean the canal spaces. So when we look at a series of papers that have been published in the past, we know that every adjunctive cleaning technique that we use makes the canals cleaner. And it doesn't matter how you do it, you always get cleaner canals when you use an adjunctive cleaning technique. Okay, so this is the simplest. Manual dynamic agitation. The canal has been prepared and it's been irrigated. The canal is now full of irrigant. You can take a GP cone and manually pump this GP cone up and down inside the root canal. Okay? And what this does is it creates hydraulic pressure and it allows irrigant penetration within the root canal space, a concept first developed by Pierre Machetoux. And it allows the lateral movement of the irrigant within the root canal space. Now, if you look at, and I'll show you the references in a couple of minutes, if you look at the papers published around this concept, the idea is that you do this 3 or 4 times with 100 cycles and you replenish the irrigant each time. So when we then move on to, so this is particularly Siobhan McGill and Andrea Huang's papers published in the IEJ in 2008. And they used an artificial tooth model with an artificial biofilm, and they showed that this technique was effective and certainly more effective than syringe irrigation at removing an artificial biofilm from the root canal wall. So the problem with that is it seemed to be time consuming. It's cheap, it's simple. We've all got tweezers and GP cones in our surgeries. So it's something that you can do straight away that's very easy. Automated devices obviously make our life that little bit easier because they can be faster and less fatiguing. So one of those devices is called the endoactivator, which is something called a sonic device. And you can see here, it has a right-angled head, which makes it easier to get into the root canal space. And these tips here are disposable and they just clip on. And the idea is that the tip of this then vibrates laterally. And as it vibrates laterally, you get fluid movement within the root canal space, which gives you effectively better cleaning. And the phrase that was coined with this was tsunami endodontics. Sorry. And this was developed by somebody called Cliff Ruddle in America. And here you can see the tip of the instrument vibrating laterally, and it's important when you have a vibrating tip that you move the instrument up and down inside the root canal to effectively get the tip moving along the entire length. So the instrument tips are 22 millimeters long. Again, they have depth markers at 18, 19 and 20 millimeters. They come in 3 different tip sizes, 20, 25 and 30. And the idea is you run this instrument for 30 seconds per canal after you've done your shaping for effective cleaning. Now, when we're using 2 separate irrigants, and I'm using EDTA as a separate irrigant, I like to use this instrument, especially with my EDTA, because while it will disperse the EDTA, because it's a non-metallic instrument, I'm not going to cause as much damage to the root canal dentine as if I used something like an ultrasonic device or if I used a mechanical debridement device, because what they are effectively doing is activating the EDTA and removing more dentine. So the more dentine that we remove, then the potential fracture resistance of the tooth becomes reduced. Because the tooth dentine becomes weaker. So very simply, battery operated. The one thing that you don't do is sterilize the handpiece. Ask me how I know not to sterilize your handpiece. So very simple clip-on. Now the one thing I like about the clip-on is if you've got a hard to access case, you can actually put the tip into the root canal first, because you can pre-bend these polymer tips and then attach the head of the handpiece to the tip while it's in situ before you then activate the device itself. So here you can see Cliff bending the tip of the instrument to create a curve. So these are the depth markers here. You can see at 18, 19, 20. You can pre-curve it to drop it into a hard to access case, or if you've got a curved canal, just very, very simple Adams pliers. And so this is a nice, neat way of stirring up the irrigants within the root canal space to get better cleaning. So when we look at published data, there's good published data that shows it is better than static syringe irrigation alone, and it does create irrigant penetration, and there's data out there showing it can be effective at removing microorganisms in biofilm form within root canals as well. So one of the other things that we've used for many, many years is ultrasonic agitation of the irrigant. And the early work that was done in this back in the early 80s and certainly in the early 90s were very much looking initially back in the early 80s at using files to shape and clean the canal simultaneously, and it proved to be a bit of a disaster. The problem was with using files is that the tip of the instruments break, and because the instrument is a file, it also cut the root canals. So what you ended up with was very, very irregular root canal spaces, which when you'd spent time preparing the root canal to a specific apical size and creating the taper, the last thing that you want to do is go and then overcut the dentine and completely destroy your root canal shape that you've created. So with the ultrasonic instruments, it's different from the endoactivator or the sonic device, which is fixed at one end and the tip vibrates. Because when we use an ultrasonic device, we get multiple waves of movement of the instrument. And if we look at the ultrasonics, and we go back to look at Guttart's paper and Burleson's papers, they showed very clearly that shaping and ultrasonic cleaning of root canals was significantly more, left the canals significantly cleaner than shaping alone. And this is at every level within the root canal space. So we know that ultrasonic activation of irrigant is an effective way of cleaning the canal. We also get, with ultrasonic activation, some heating of the irrigant, and that heating may make the irrigant more effective. Certainly with hypochlorite, it may also make the irrigant, the sodium hypochlorite, exhaust more quickly, requiring replenishment. What was in fashion at one point and that sensibly has gone out of fashion was running the irrigant through your ultrasonic device over the head of the handpiece. And the problem is the sodium hypochlorite, when you pump it through your device, destroys the pump. And so you end up with a broken ultrasonic box. So the whole idea of this is passive ultrasonic irrigation. So again, you do your shaping processes, you put the irrigant into the canal, you introduce the device and you let it vibrate. And you can see here, this is Ahmad's work from 1987. This is some of the research I did when I was doing my master's degree. And this particular ultrasonic device is called an Irrisafe. And you can see the lateral movement of the irrigant here at specific places, these nodes along the length of the tip of the instrument. And so what we actually get is rapid, violent movement of the irrigant within the root canal space. And so the concept of cavitation, where we have the sonic movement creating air bubbles which then get pulled around and collapse and release energy, is thought not to be the reason why root canals get cleaned. It's thought to be acoustic microstreaming, which is what they showed here, which is the movement of the irrigant around the instrument itself. So again, because you've got multiple nodes and you've got multiple points of movement, these instruments need to be moved vertically within the root canal space to allow the movement of the irrigant to have its maximum benefit along the entire root canal system. So this instrument, you don't need to take any closer than 1 millimeter from the working length. They come in two sizes, a 20 and a 25. So you must make sure that you've created an apical size and a taper large enough to accept the instrument, because if the instrument contacts the dentinal wall, you get something called contact dampening. So what happens is you get loss of vibration. And if you get loss of vibration, you get loss of movement of the irrigant, so you lose the effect. So what you want in an ideal world is the instrument to be in the middle of the irrigant in the root canal to get maximum effect of the movement of the irrigant around the tip. So the amplitude of oscillation here on this particular instrument on the size 25 is around 30 ISO. So when using these instruments, your canal at 1 millimeter needs to be at least a size 30 to keep it free and moving. Sorry, let me just come out of this a second and find out why that's not playing. Would do. So, sorry everyone. I checked all this earlier on, it was fine. What you'll see here is that the irrigant itself gets pushed laterally and we get eddy currents all the way around the instrument, which is what cleans the root canal itself. So what we found, though, the problem with ultrasonics is this altering of the canal shapes, particularly when we use files and particularly when we use an EDTA solution. The combination effect of ultrasonics and EDTA causes severe damage to the root canal wall. So coming into looking at root canal anatomy and the problem of the oval root canal in relation to shaping and cleaning is that when we have an oval root canal, obviously we have the minimum diameter and we have the maximum diameter, and our shaping processes are poor at contacting the maximum diameter unless the canal is significantly smaller than the files that we're using. So if we look at this micro CT of this lower molar, you can see the distal canal here. If we use a canal that's going to contact the maximum diameter, the chances are we're going to create a strip perforation on the mesial surface of that root. And when we start to look at the residual dentine thickness, the further apically we go, the more we try and do that with our files, the weaker or the thinner the canal wall is going to be, so potentially the weaker it's going to be. When we look at the incidence of vertical root fractures occur predominantly in root canal filled teeth, and they occur from the internal surface of the canal wall and then propagate to the external surface and then move coronoapically. So the more dentin we remove, then the weaker we leave the tooth. So we need to have a compromise because we need to increase the canal size so that we can irrigate. So we need to increase the volume through taper creation, and we need to increase the apical size to allow irrigant penetration and allow us to get adjunctive cleaning instruments in there. So if this is our original root canal anatomy, okay, if we work to the minimal diameter, you can see the green here shows the amount of tooth or amount of root canal that remains completely uninstrumented, but it also leaves the maximum amount of root canal dentine behind. If we work to the maximal diameter, you can see the problem that we've got is we've, in this particular graphic, strip perforated the actual tooth itself, and we've removed all of the dentine and come out the side. So we have to compromise. So we create an apical size and a taper or volume creation to allow us to clean these untouched spaces. In an ideal world, we wouldn't shape that space at all, we would just clean it. Now, the problem with that is that's easy to say and difficult to do because our irrigants don't flow particularly well within the root canal space. And so if we don't do any shaping at all, we're going to struggle to actually get penetration. So coming back here, back to Frank Piquet's work again, similar to Peter's work in 2001, looking at subtraction micro CT, we can see that shaping and cleaning always gives us cleaner root canals. So we have to adjunctively stir. So one of the big things that we've had is progression of nickel titanium alloys over time. And this is where we're starting to see improvement in instrumentation. But the other that we're starting to see is with the new alloys is instrument designs, not just for shaping canals, but also for adjunctive cleaning techniques. And so when we're looking at the nitinol 55 alloy, which is what we would call NiTi. So nickel titanium, the NOL is Naval Ordnance Labs, 55 nickel percentage, 45 titanium. This can exist in two phases, something called austenite and martensite. Now, austenite is the shape memory classic file nickel titanium that when you bend it, it springs back. Now, the problem with those instruments, as good as they are, is they're susceptible to fracturing from cyclic fatigue. So when you stick them around a curve over time, the wire gets bent backwards and forwards and eventually they break. What was discovered is when you incorporate more of the martensitic phase into the nitinol alloy, then you actually get more resistance to cyclic fatigue just by changing the alloy. And so M wire was born. It has more martensitic phase in it than the austenitic phase. And the very latest generation of NiTi alloys that we've got are what we would call the controlled memory. So the martensitic alloys are the controlled memory instruments. And I think HiFlex is one of the ones. We have Pro-Taper Gold, Wave 1 Gold, Reciproc Blue, to name just a few of the instruments that took advantage of moving into the martensitic instruments with a controlled memory shape. So when we look at what controlled memory actually means, so this is a martensitic nickel titanium alloy, and you can see that it can be manipulated out of its original paperclip shape. Now, what the clever thing about this alloy can be is it can be made to be heat sensitive. So when the alloy is deformed, when you heat it, it can create a different shape. Now this caused us a problem with the original nitinol 55 alloys because when it deformed and you stuck it in an autoclave, it would reform and you couldn't spot where it was going to fail. So you can see here, even with the paperclip being turned into a helix or a spring, it still has the ability to have shape memory. So if you can take this concept into instrumentation within root canals, what you can have is an alloy that can, in a file form, can be pre-bent and moved into a canal, particularly if it's difficult to access. And yet when it's at body temperature, it will create more austenite, which means it still cuts effectively and efficiently. So this has allowed novel instrument design. And FKG as a company took advantage of this concept and came up with two instruments initially made from this alloy. And this was designed specifically for adjunctive cleaning of root canals. So this is made from an alloy called Max Wire, which is a martensitic nickel titanium alloy. And this alloy is designed at body temperature to become stiffer. So this instrument is designed to mechanically clean root canals. You put it into your endodontic handpiece and you introduce it into the canal, and it effectively scrapes the canal walls. So when you look at the design of the instrument, it has a size 25 tip. It has no taper, so it's completely parallel. It has a square cross section, and this isn't designed and doesn't actually cut root canals. So when this is put into a tooth with greater than 35 degrees, then it becomes stiffer and it forms this loop. Now, this loop is the bit that, in theory, makes this instrument a clever instrument. So what happens is, I mean, when you take these out the packet, even at room temperature, they look like this anyway. So when it's at body temperature, from the straight to the looped form, it's 1 millimeter shorter than its full extended form. So when you're using it in a canal, it's really important that you set your working length 1 millimeter short of the length that you shaped to. So the other thing that happens is this loop is approximately 3 millimeters wide, which is an ISO 300. So the idea is that this instrument is put in your handpiece and is used up and down inside a canal full of your irrigant to scrape out the shaping debris and disrupt the biofilm and create tubular penetration without needing to invest in a new piece of equipment. Effectively, you use it in your endo motor and your endo handpiece. So this instrument takes advantage of the concepts of the controlled memory of nickel titanium moving from its martensitic phase to its austenitic phase at body temperature. And if we look at an example here of it working, you can see it holds this shape in the canal space, and the idea is when it's in the canal, you move it from the orifice to 1 millimeter short of the working length. Even if you get some compression of the instrument, you have to remember that it will only go, even if you completely straighten it, 1 millimeter longer. So it will not go through the apical foramen as long as you've got correct working length. So it's a mechanical debrider that we move vertically up and down, and this is done for 60 seconds per canal. So here, this is a plastic block with plaster of Paris. This has been prepared to a size 35 with an 04 taper, standard rotary night-eye file, and then this is full of water. And you can see the instrument is rotated and brought up and down along the entire length of the root canal space. And by moving this instrument up and down within the root canal space, hopefully we get mechanical debridement of that space. Okay, so we do this for 60 seconds, or the FKG recommends that you do this for 60 seconds per canal, and it's a relatively slow movement. It's literally one cycle every 2 or 3 seconds. The idea is you want to give the instrument plenty of time to contact the canal wall. And by one movement, I mean advance to working length and then come back to the orifice over approximately 3 seconds. And you can see from this set of still images here that the instrument was always in part of the root canal. And as I say, it has the ability to occupy space the equivalent of an ISO 300. Flexibility, this is why we don't want to put it through the apical foramen. Although there have been instruments designed and recommended for macerating the apical granuloma, I would recommend that you don't do this. Control is everything in endodontics. We want to make sure that we keep everything in the root canal space. So looking at an example on a 3D printed tooth. So this is courtesy of Gilberto de Bellion. And this is a 3D printed tooth of the distal root of a lower molar. And this is a standard taper, 30 tip 04 taper instrument, so it's a non-shielded preparation. And you can see we get nice shaping, but the wax in here is what's left behind. Okay, if we could do that clinically, quite useful. So here, the concept is that the irrigant is delivered into the root canal after shaping, and then the XP finisher, as it's called, is introduced and then rotated. Okay, so you put it into the canal first and then rotate it, and then you let it just do its thing. So there's no point in trying to move it because you can't control what the instrument is actually doing. And what you're aiming to achieve is contact of the instrument. You can see its ability here to move laterally and to contact the instrument within the root canal space. And if you look at the distance between the distal buccal and the distal lingual canal shapes, they are very, very different. And with your sodium hypochlorite in the root canal here, what you're aiming to do is dissolve any residual tissue that's in there, but also disrupt the biofilm and get tubular penetration. So you can see that instrument there has the ability to contact laterally. And it's the same here. We have literally an apical trifurcation. Okay, and it has the ability to clean in those spaces, but you've got to give it time for it to be effective within there. A couple of examples of this being done on the bench top, unprepared, prepared by shaping, and this is what I was saying earlier on about residual dentine thickness with our shaping processes. And these canals here haven't been shaped at all, they've just been cleaned. And again, looking at a micro CT, the mesial canals of a lower, the distal canal of a lower molar here was prepared to a size 40, and we can still see residual shaping debris. So shaping and cleaning gives a better result. Same's on the mesials. So coming back again, looking at the shaping side and the shaping and cleaning, time and time again we see that shaping and cleaning root canals is the best way to give us our best results. So looking at a published paper in the Journal of Endodontics, and here this is syringe irrigation, positive passive ultrasonic irrigation, something called the self-adjusting file, the SAF file, and then something called the XP Endo finisher, which is the instrument that I've just shown you. Now, for a long time, passive ultrasonic irrigation was considered to be the gold standard of cleaning root canals. And so obviously when something new comes out, we need data to show that it's as effective or more effective than what we're doing already. And this paper here suggested there was no difference between passive ultrasonic irrigation and the XP finisher group. So that's quite nice. The only observation in this particular study model is it appeared with PUI that there's more debris apical, and with the XP finisher, more debris coronal. But please remember, that's just one shape of root canal system, and it's an artificial model, but potentially it works. So comparing, looking at PIPs, photo-initiated photon sensitization, and looking at the XP finisher and looking at the endo activator, they were all effective. PIPs was extremely effective, and there was, in this particular study, tubular penetration with the XP finisher. So it appears that this instrument may have a place within our endodontic processes, and may have a place within endodontic techniques to get better cleaning and better irrigation of the root canal spaces. So looking at some of the published papers in the JOE, there is also the potential ability for using this instrument in retreatment. The retreatment version of this instrument has a size 30 tip rather than a size 25 tip, which gives it more stiffness, but it's there potentially to help us in retreatments as well. And here, the reason I put this in is because it's one of the few papers that's been published looking at etidronic acid and hypochlorite and using adjunctive cleaning techniques. It's an ex vitro, it's an in vitro model, you're looking at artificially induced internal resorption lesions, and in this particular model, it was effective at cleaning that. I just want to briefly cover, if I may, sorry, excuse me. Negative pressure irrigation. Okay, so Endovac is a system whereby instead of injecting sodium hypochlorite into the root canal, which is what we do with our syringe irrigation, you have an alternative method of doing this. And the alternative method is actually to suck the irrigant down into the canal and then draw it back out, which is what we call negative pressure irrigation. Now, negative pressure irrigation is an incredibly safe way of delivering irrigants into the root canal space because we're not injecting it. And if we're not injecting it, then we're not creating a positive hydrostatic pressure, which means we're keeping safe apically. Again, because if you look here, you can see the apical airlock. Okay, even with instrumentation here, the apical airlock can still exist. Okay, so after shaping, introducing the irrigant, we don't want positive apical pressure that exceeds, okay, that allows the irrigant to go through the apical tissues and create a hypochlorite accident. So Endovac is a useful system whereby the irrigant is sucked down into the canal space and has a safer method of delivering irrigant. Okay, so thank you for your time on a Monday evening. That's not bad. I'm 5 minutes ahead of myself, which is unusual for me. Normally I go on significantly longer, but I think that's probably because a couple of the videos didn't fully play, so my apologies for that. Are there any questions? I've seen a couple in the Q&A. Okay, Lou, how are we going to do this?
Yeah, can you see the questions in the Q&A? If I just stop your sharing. Can you see them there, James? Or
okay. Which picture of the infection in particular are you after? I've got chats and I've got Q&A.
I think you could just...
Yeah.
Yeah.
Shaza, there's no evidence yet that it causes damage. They can break. Okay. Torque is 1 Newton centimetre and speed is between 800 and 1000 RPM. As I said, the only potential drawbacks of using the XP finisher are if you are getting them into the canal in the first place, it can be difficult sometimes. So what happens is that the instrument doesn't actually get into the canal. So it can bend in the access cavity and then bend back on itself. According to your researches, are you trying to say that every dentist in the world is not irrigating properly? No, I'm not saying everyone's not irrigating properly. What I'm saying is that shaping is only part of our technique for cleaning root canals, Camwell. We need to have, if you look at a lot of endodontics now, irrigation is understood and believed to be an exceptionally important part of endodontics. So what we're trying to do constantly is look at improving the cleanliness of the root canals and also look at safety of delivery of irrigation and look at reducing the microbial load. Do I recommend Irriflex for all dentists? No, I don't. I think Irriflex is a nice concept and it's out there. As for how much it costs, Camwell, I honestly don't know. I have used them, I quite like them. I have had some issues with the tip buckling and blocking, but I suspect that's probably me. Okay, irrigation for vital and non-vital. Riyadh, I do the same for both, to be honest with you. So I do all my shaping with sodium hypochlorite. If I'm using a 2 irrigation system or 2 irrigant system, once I've done my shaping, then I clean all the canals with sodium hypochlorite, depending on what system I'm using. If I'm using the XP finisher, then I'll use that for 60 seconds per canal. Then I will dry the canals. Then I will introduce my EDTA solution and use my endo activator for 30 seconds. Then I'll write up my notes. Then I will dry the canals again. Then I will introduce my sodium hypochlorite one last time and do cone fit. Once I've fitted my cones, I take a cone fit radiograph. So the cones are fitted in hypochlorite, which disinfects them. And also hopefully gives me some of the manual dynamic effect of hydraulic displacement of the hypochlorite laterally into the spaces that have been opened by removing the smear layer. Have to remember, smear layer is only going to occur where your file has contacted the dentine. So in the places where your file hasn't contacted the dentine, you're not going to get smear layer. So then once I've done my cone fit and I've done my cone fit radiograph, I will dry the canals again, and then I'll go through my obturation process. So hopefully that answers that question. What was the accident? That was a hypochlorite accident. That's where the sodium hypochlorite had been forced through the apical foramen under pressure, which is exactly what we're trying to avoid. Yeah, so Kamal, that's what that was. That was a very, very extreme sodium hypochlorite accident. Oh, hi, Maxine. Nice to see you. Hope you're well. Hi, Shyster. No, it doesn't. The Irriflex doesn't. It's not that I've seen. It's a 30 with an 04 taper. No, it's not a line 20 specific rotary system. And as I say, it's a Lua lock, so it will go onto any syringe that you've got that has a standard Lua lock attachment to it. No, I would say the only thing that the dual rinse has allowed me to do is drop my EDTA soak, because the dual rinse, when I use it, I don't use it in retreatments because I don't see the benefit, because I've got to get out what's already in there and then I've got to clean it afterwards. So I think during a retreatment, it's a waste of product. So no, I don't use it for retreatments. But I do use it for primary treatments because it prevents the buildup of the smear layer. Needle gauge, 27 gauge is the most common, Zena, and that's the one with the yellow hub on it, and that's equivalent to an ISI just over size 40. The 30 gauge is useful because where we're going with minimally invasive dentistry is coming into endodontics as well, so trying to get more parallel preparations to try and preserve more dentine. But the problem when you do that is you can't get your needle in, and if you can't get your needle in and get in needle penetration, there's always a risk that you're going to wedge the needle, and that's exactly what we don't want. I personally use a minimum of 3% sodium hypochlorite straight out of the bottle. The higher the concentration, the more effective it is against necrotic tissue, and the more effective it is against the spectrum of bacterial activity. The problem is the higher the concentration, the more cytotoxic it is, and also the higher the concentration, then potentially the more of the organic tissue it dissolves, so the more brittle the tooth becomes. So hopefully, Connor, that answers that question. Yes. Mohammed, I'd probably agree with you there. I think that's just simple syringe irrigation. It really doesn't clean canals. I think we all accept that now. So simply just depositing irrigation into the canal with a syringe does not get rid of the shaping debris and doesn't get tubular presentation. I haven't used, Simran, I haven't used True Anatomy's irrigation needle yet. I'm looking forward to having a look at that and looking forward to trying that out. I think that anything that helps us be safe and takes the stress out of us potentially having an accident is good, because that gives us more confidence. The recommended concentration of sodium hypochlorite, I think that depends on where you practice, Zishan. Certainly in America, the trend tends to be for much higher concentrations, and in the UK, or certainly in Europe, I would suggest the trend would be to lower concentrations. You have to remember that the lower concentrations require more time, but they are less cytotoxic. I think also as well, if you look at the American philosophy, one of the reasons for using higher concentrations is the potential concept of doing single visit endodontics. The European missive tends to be a lower concentration, 2 visits of endodontics, although the evidence on that is poor. That a single visit versus multiple visits has a better outcome. And I think at the moment we're slightly strange with the COVID environment because we're trying to encourage everybody to do everything in single visit. But I can promise you, having been stuck in an FFP3 mask for over an hour and a half, I'm doing more multiple visit endodontics than ever before at the moment, because it's just so exhausting and so tiring being under that kit for a long period of time. GP for obturation, yeah, that's really comes down to personal choice and preference. I think that there's a long way to go with our calcium silicate cements. So things like BioSeal and Total Fill and these sorts of products. I think that's potentially the future. It's by far and away no way perfect at the moment. And I think that these products, because they're so biocompatible, have a part to play in our endodontics. They certainly do with vital pulp therapy, perforation repair, and they are certainly here to stay in obturation. Am I convinced totally about single cone obturation with calcium silicate cement? I'm not entirely sure I am. Do I like the products? Yes, I do. Do I think they're of benefit to us in a lot of ways? Yes, I do. I just think that we haven't necessarily, unless you're using cold lateral compaction, I don't think we're fully there yet with the concept of filling the whole canal with a calcium silicate sealer and then leaving it at that. Excuse me, my voice has gone funny. For me personally, Zishan, because I always use 3%, and in a vital case, the majority of pulp extirpation is probably mechanical anyway. So that you can vary it, of course you can. But you know, I like to go somewhere in the middle and keep safe. Specific amount of irrigant per canal shyster. I think the problem with that is how do you definitively, hey Hassan, how do you definitively decide how much is enough? I think the problem that we have is that we know that we can under irrigate root canals, but I think there's so many variables that go into it: time, temperature, concentration, how infected the case is, how effective our shaping processes are, amongst other things, that I think that my answer to that is use as much as you can. So use as much as you can and replenish it frequently. Hassan, great to hear from you. I hope you're very, very well. It's lovely to see you. Do I prefer as a lubricant for rotary files? It depends on the case. For most rotary files, if it's not a calcified case, then sodium hypochlorite is fine. If I'm using hand files in a calcified case, then EDTA liquid is, or paste is absolutely fine. I think where I struggle is using EDTA paste with rotary niti. Rotary niti and pastes, because of the way niti cuts, pastes block the files, so can cause a problem. So I think the take-home message from this is never use a file dry in a canal. I wouldn't criticize you for using EDTA solution or sodium hypochlorite with rotary niti. Yeah, Jitu Sonendo is eye-wateringly expensive, but does seem to have, or does seem to be extremely effective from what I've read about it. It does seem to be a very, very good system, but last time I looked at it, it was an awful lot of money. Intracanal medicants, yes, I do. Yeah, Shyster, I always dry. The one thing that you might be seeing there is that people are mixing chlorhexidine with with calcium hydroxide as an intracanal medicament. If I'm placing calcium hydroxide as a multiple visit, then I would dry first. Okay, so Mohammed, when do I do a pulpotomy and irrigate the coronal part? If I'm going to do a vital pulp therapy and I'm going to do a pulp preservation technique, it's really important that the patient, there are papers published that show success with cases of irreversible pulpitis, because when you look at the histological slides, when you have an irreversible or a reversible pulpitis, then it's not all of the pulp that it's inflamed. So the trick there is to remove the inflamed pulp tissue, but the problem is you can't tell that clinically. So for me, if a patient has got a reversible pulpitis, so they've got a carious exposure, they're getting symptoms, they're not spontaneous and they don't linger, then it's worthwhile at that point considering doing a vital pulp therapy technique, but that's an entirely different lecture. Ian, re-RCT with bioceramic, I haven't had a problem with that. Thank you for your compliment. I really, really appreciate it. That's very kind of you. No, I haven't had a problem with that. It's not as hard as something like MTA. It's designed, so it's more like a soft plaster of Paris. So the other reason for using a GP cone is once you get your GP cone out, you then effectively have a lumen. There's some discussion and debate over regaining patency, but I tend to find that, to be honest with you, with a lot of retreatments regardless. Sorry, gel versus liquid EDTA. Yeah, gel EDTA paste is designed really for working with hand files. So rotary niti files have very deep grooves in them. So the deep grooves in them, if you put a paste in those files, has the potential to block the file and prevent the shaping debris going into it. And so there is some suggestion that it will then reduce, when the file's cutting and the debris is packing around the file rather than going into the file, that it will block the file and it will make it less flexible and therefore more susceptible to fracture. So generally with rotary niti, I prefer to use a liquid lubricant. But you know, if I'm going to hand file, if I've got a really calcified case or a really narrow canal, I'm predominantly going to hand file it first anyway, because I've got much better tactile sensation of those instruments and I can control them in those spaces and pre-curve them and then gradually do a preparation and hopefully minimize my chance of fracturing an instrument. So yes, RC Prep and Glide, I do use them regularly on difficult cases, but only with my hand files. I don't use them with rotary files. Hopefully that answers your question, Patricia. Shahir. Hi, Shahir. Yeah, that's a great question, Shahir. Because, and the great reason that you ask it as well, because the calcium silicate cement's obviously set in the presence of moisture. So if you desiccate the tooth completely, there is some potential thought process that at that point you are not going to have sufficient moisture to actually set the cement. If you go back to Pathways of the Pulp, there is some suggestion in Pathways that a non-vital tooth only has 9% less moisture than a vital tooth, and when we're using our paper points, then we're drying the lumen and not necessarily the tubules. So I think that this is one of the faults within the technique that we can argue. I think maybe it might be a bit academic, I'm not sure. I certainly haven't come back to a case where the calcium silicate hasn't set. And you have to remember with the calcium silicate cements, not that they're different to our traditional cements. They don't set into like 2 to 4 hours. They get an initial set and then gradually over a period of weeks or even months, according to Josette, is they reach a greater hardness. So hopefully that answered your question. Yeah, Hassan, as long as the patient has irreversible pulpitis, if you go back to the presentation looking at particularly Bogan's work, it's all about getting hemostasis at the level of exposure. So as long as you can get hemostasis, some people are talking about sterile cotton pledges in sodium hypochlorite and applying pressure. That's certainly been published as working well. I prefer a passive technique where possible. So Bogan's technique is my preferred technique, but that doesn't make me right and them wrong. It's just horses for courses. Shahir, no problem. I hope you're well, and I hope your family's well. Has that answered everybody's questions?
I think it has. That was a mammoth Q&A session.
Mary Island. How lovely. Well, thanks everyone for attending. Have a lovely evening. I hope you're all staying safe wherever you are in the world in this particularly peculiar time that we're working in at the moment. It's been an absolute pleasure talking to you all, and hopefully we'll meet again soon.